So I'm going to show you a case here, and I know some of you may have seen this before, but I think most of you probably have not. Here are my disclosures. So this was an 85-year-old woman. She had had previous surgical repair done elsewhere about 8 years before she came to see us. She was 85, she was a bit frail and clearly symptomatic, was essentially class 3. She had a very difficult family, and to say the least, I know, Susan, you may remember this family, but she really wanted something done, and she pushed really hard, but this is what we were dealing with. So if you look here in the top left, you can see that the posterior leaflet has been resected. She's got an annuloplasty ring. She's got some MR, which you can see here both in the LVOT and the BICOM view. And you can see that for mitral clip purposes, this anatomy could be quite challenging. Here's her 3D image, and you can see this partial annuloplasty ring. We tend to prefer complete rings. For whatever reason, she had a partial ring done elsewhere. And as is quite common with mitral valve surgery, she did have some elevated gradients. Here is a gradient of 2.
What's wrong with that ring? That partial band?
Well,
Well,
the issue, okay, I'm not a surgeon, but my understanding is that the issue with these is that the implantation did not go far enough to the trigones. Yeah, and exactly. Exactly. So that it slipped down or wasn't implanted, and so the remodeling happened that way. Absolutely. So here we're looking at this patient. She's desperate. She really doesn't want to avoid surgery. So we offer mitral clip. So I'll just show you in the interest of time of how we did it. Now the key here is that the posterior leaflet had been resected. There's very little, if any, posterior leaflet tissue. So you got to think to yourself, well, what are you going to anchor the posterior arm of the clip to? Well, we're just going to find something to anchor to. And the reason why that's important is because when you do that, you want to have your transeptal relatively posterior, because you're going to be pulling the CDS posteriorly to grab whatever tissue you can grab. And so here we're going to go right down the middle because that's where most of the MR jet is. And here we've got the clip lined up. And what you don't see before here is that essentially I've taken that posterior arm of the clip and essentially pushed it over as a bumper over the annuloplasty ring. And that just tells me that I've gotten as posterior as I can, and then I pull as posterior as I can. And the posterior arm here is sitting on the annuloplasty ring. And then we've closed the clip, as you can see here. The posterior arm has a ring in it. There's an anterior leaflet in here. And the gradient, which to my chagrin, because I thought, the gradient of 2, I thought we were going to end up with a gradient of 8, 10. It actually only went up to 4. So here, as one of the concerns is there's not a whole lot of tissue here. So I'm going to tug on this like there's no tomorrow. So I'm tugging on this, making sure it's rock stable, because the last thing I want to do is see this go into the patient's head. And so here I'm tugging on it really hard, and you can see, there's the radiopaque portion of the annuloplasty band, but there's obviously the band that you can't see that the clip is anchored onto. And after we're quite happy with how this is secure, you can see here that we've left it behind. And this is the final result. And so you can see here the clip is on the annuloplasty band and the anterior leaflet. The MR has been completely relieved. And if you look at this, that anterior leaflet has been brought over onto the posterior ring here. And this is the color flow showing the improvement in the MR. Now this was done a few years ago, and looking back, this amount of tethering, you might think, maybe we should have considered putting another clip in here. I think I probably would, just to make sure that the anchor of this would be secure so that we don't end up with an SLDA. But again, to my pleasant surprise, she's done very well in terms of her MR therapy. So key points, go very posterior if you have posterior leaflet that's deficient or absent. You always want to be wary of stenosis, because with surgery, it's going to be a downsized annuloplasty when they do surgeries. It's always going to be smaller than the native. And in this patient, I had some concerns about this valve being small, but if you look here, look at the pressure half-time. A major reason why this patient's gradient was elevated was not because of the MS, but because of the MR, because the pressure half-time is actually very, very short here. So that can also give you a clue as to whether stenosis is going to be a problem. So thank you very much.
A great case, Paul, and thank you. We saw you do this before. So my quick question was, I was expecting the mitral clip to have a little bit more wider with the ring inside,
Yeah.
and I wanted to see how much it pulls the anterior leaflet and how much the wideness of the clip should be. And fluoroscopy didn't look that wide.
Yeah, you're right. And I don't know if it's because maybe I wasn't truly on the angioplasty ring, and maybe I just grabbed some posterior leaflet tissue and cords, and that's really what we're anchoring to. And maybe I shouldn't be saying that we were on the ring.
Right.
Probably are on tissue, Paul, because when we do this,
Yeah.
they didn't cut out all posterior leaflets.
Yeah.
We really can't do that.
Right.
Whenever when you do a resection,
Yeah.
put them in, it looks like there's no posterior leaflet. Now, if you just do cords, they leave some
Yeah.
posterior leaflet, right? But it then sticks backwards, so there's something behind it that you can't see that you're probably grasping.
So that's exactly what we did. We just hoped that whatever tissue there was, yeah, that we grabbed. So that's a great point for doing this. Just grab whatever you can't see.
Right. I guess we don't really know the long-term durability of doing this, but
No.
you know, I think you'll have to be really cautious and really certain that you have a really good grasp on the anterior
Yeah.
leaflet in these cases.
Absolutely.
Yeah. Great
Thanks,
case.
everyone.